Emergency department case presentation. Clinical presentation. A 32 years old male was brought to the emergency department by his family approximately 45 minutes after an accidental ingestion of an unknown substance. Chief complaints Chief complaints includes excessive salivation, vomiting, sweating, difficulty in breathing, progressive drowsiness, and altered level of consciousness. Vitals on arrivals were: his heart rate was 48 beats per minute, blood pressure 90 by 60, respiratory rate 10 breaths per minute, oxygen saturation 84% on room air, GCS includes 8 by 15, RBS was 108 milligram per deciliter. Primary survey includes airway, breathing, circulation, disability, and exposure. A for airway, in its findings includes excessive oral secretions, gurgling sounds, airway partially obstructed. Management. Initially, immediate suctioning was performed, high flow oxygenation was given, as GCS was low, so rapid sequence intubation performed. B for breathing, finding includes respiratory rate less than 10 per minute, oxygen saturation 84% on room air, and chest there was auscultation, there was bilateral wheeze with bronchoria. So initial ER management was done, mechanical ventilation after post intubation performed, continuous pulse oximetry done, in tidal carbon dioxide monitored. C for circulation. Findings were BP 90 by 60 mmHg, heart rate 48 per minute, which is bradycardia, and extremities were cold. Initial management: 2 large bore IV cannulas passed, 2-liter normal saline bolus was given, and continuous cardiac monitoring was done. Disability includes findings: GCS, eyes were responsive to pain, verbal response was 2, and motor 4. So total GCS 8 by 15. Pupils were pinpoint 1 mm and equally reactive. There was only generalized fasciculations. E for exposure, findings includes clothes were contaminated with pesticides. In management, we removed all the contaminated clothes, washed the body thoroughly with soap and water. Staff was in full PPE. Initial investigations were sent. Initial investigations ordered includes ECG, ABGs, electrolytes, blood glucose, CBC, urea crate, chest X-ray, serum cholinesterase, sent treatment now delayed, and urine for toxicology. Initial ABGs performed showed pH 7.24, carbon dioxide 60 mmHg, HCO3 25 millimole per liter. So initial interpretation was done, which showed type 2 respiratory failure as carbon dioxide was collecting inside the body. So initial diagnosis made was acute respiratory acidosis due to hypoventilation. This is the ECG of patient in which the heart rate is low, so it is showing bradycardia. Other findings of ECG are normal. This is chest X-ray of patient in which there is infiltration, which is showing bronchoria, though chest was bilateral wheezy on auscultation due to much secretion secreted by poison. This is the CBC test of patient in which HB is 14.6, WBC count is 6.800, platelets count to like 56,000, which is normal. Urea crate, blood urea was 18, serum crate 1.0, BUN by crate ratio was 28. Electrolyte test was performed which showed sodium 139, potassium 4.1, chloride 101. Definitive management was started. Definitive management includes atropine titration. First of all, IV bolus 2 mg atropine was given. If the secretions were persisted, as the secretion was not slowed down or finished, so then we doubled the dose. 4 mg IV bolus was given. The secretions were also persist, so 8 mg IV bolus was given. Then total 18 mg of atropine was given to this patient. Titrated to clinical endpoints, not fixed dose. It means that titration shall be done till the chest become clear, bronchoria and wheeze resolved, heart rate become 48 to 90, which means bradycardia has been corrected, and secretions were dried. Oral and bronchial secretions were stopped. The BP of patient was improved. as the atropine reverses muscarinic effects, includes secretions, bradycardia, bronchospasm, but does not treat the neuromuscular or nicotinic weakness. Pralidoxime in supportive care. Pralidoxime 2-PAM. It reactivates the acetylcholinesterase, which is most effective when started early. Its loading dose is 2 gram IV over 30 minutes is given. Continues in infusion for 24 hours. Then on maintenance dose, it will be continuously given for 24 hours, given alongside atropine. Atropine controls muscarinic symptoms, while pralidoxime addresses the underlying enzyme inhibition. One controls muscarinic symptoms, and the other addresses the underlying enzyme inhibition. Supportive care and ICU admission was advised to the patient. Supportive care includes mechanical ventilation, IV fluids, Foley's catheter, NG tube, DVT prophylaxis, stress ulcer prophylaxis. After that, a patient was admitted in ICU. Clinical course of patient. Patient was admitted in ICU, then ICU till discharge. What happened to the patient? After the 12 hours, the secretions decreased, heart rate and BP become normalized. On day 2, fasciculation resolved, ABGs normalized, oxygenation improved. On day 3, patient started obeying commands successfully and the patient was extubated. Day 3, patient started eating orally with and walking with assistance. Day 5, transferred from ICU to the medical ward. On day 6, patient was discharged to home in the stable condition. Final diagnosis was made include acute organophosphate poisoning causing the cholinergic crisis and respiratory failure, which was successfully managed with early resuscitation, atropine, pralidoxime, mechanical ventilation, and intensive support care. After the 6 days ICU admission to discharge home, evidence supporting the diagnosis includes these were agriculture pesticide exposure, cholinergic syndrome, taxidrome, which includes sludge symptoms plus meiosis plus bradycardia. There was reduced cholinergic activity, cholinesterase activity, and response to the atropine therapy.